Good evening to everyone and welcome to today's wonderful evening. Good to see Vennela, Sneha, Mrunal, Archana, Anita, and many more who are all online. Happy to see Ankit also, always smiling. Ankit, good evening. Can you hear my voice?
Good evening, sir.
Great. Good evening to everyone and welcome to today's wonderful evening. Good to see. Yes. So let's make a great beginning today. I'm going to storm you with some topics in orthopedics today. Vanilla, are you there?
Yes, sir.
Very good. So good to see Sandeep, Gurjar, Sneha, Sebastian, Samir Upadhyay, and many more. Good. So guys, I'm almost addicted to study along with you every day. There are no other priorities for me but to spend a wonderful time with you all wonderful guys. So let's make the great beginning today. In orthopedics, one of the major part is bone tumors. Bone tumors. Now, I quickly rattle out 20 points and then I will quiz you how many of you are able to remember, right? Okay, let's start. What is the most common bone tumors? It is not the primary but secondaries. The most common primary malignant bone tumor, your answer should be multiple myeloma. What is the commonest malignant bone tumor that affects a flat bone like scapula? Chondrosarcoma. What is the commonest true benign tumor? It is osteoid osteoma. What is the most common benign tumor of the spine? Hemangioma. And in which bone tumor you find bony islets? Osteoid osteoma. And which bone tumor very closely is similar to a bone infarct? Enchondroma. Now, which is the bone tumor that arises from fibrous dysplasias? Giant cell tumor. Then age and tumors are very important in the bones. Ewing sarcoma usually occur in first decade. Ewing sarcoma, unicameral bone cyst are first decade. Osteogenicsarcoma, aneurysmal bone cyst are second decade. And typically, giant cell tumor occur after skeletal maturity because it arises from the epiphysis. And what is the bone tumor which is epiphyseal, but it happens before skeletal maturity? Chondroblastoma. And always remember, first decade and a diaphyseal tumor. What is diaphysis? Shaft of the bone is called diaphysis. First decade and diaphyseal tumor is Ewing's. And second decade, metaphyseal tumor is Osteogenicsarcoma. This is a quick bombardment of bone tumors. Let me check by asking quickly 4 to 5 points how much you are able to grasp. Tell me, doctor, what is the most common benign tumor of spine?
Hemangioma.
Hemangioma.
From fibrous dysplasia, which tumor arises?
GCT.
Super. And what is the most common primary malignant bone tumor?
Multiple myeloma.
Multiple myeloma.
Commonest true benign tumor?
Chondrosarcoma.
Osteoid osteoma.
Osteoid osteoma. Very good. And which is a close differential diagnosis to a bone infarct?
Enchondroma.
Very good. Which tumor is first decade diaphyseal?
Ewing sarcoma.
Which is second decade metaphyseal?
Osteogenic sarcoma.
Super. And which is epiphyseal and arise before skeletal maturity?
Chondroblastoma.
Very good. And which is epiphyseal and arise after skeletal maturity?
GCT.
Super. So that is the quick 10 points you need to have ready to fire on the examiner, doctor. Now, certain classical radiological features, doctor, very favorite question of the examiner. Sun ray appearance, Codman's triangle. Codman's triangle means typically the tumor will lead to a elevation of the periosteum. So sun ray appearance, Codman's triangle, think of Osteogenicsarcoma. Onion peel appearance, Ewing sarcoma. Soap bubble appearance, osteoclastoma and adamantinoma. Patchy calcification, chondrogenic tumors. Homogeneous calcification, osteogenic tumors. That is what you need to basically remember. There is one named classification, doctor, for the bone tumors. It is called King's classification. King's classification is what you need to remember. Now, what are the treatment options available always? Chemotherapy, radiotherapy, or surgery. So, of all the tumors in the bone, which is radio resistant, favorite question of the examiner. Always cartilaginous tumors are resistant, doctor, radio resistant. And osteogenic sarcoma is radio resistant. That is what you need to remember. So, before we go to the next part of the game, let me quickly check 2-3 questions, 2-3 points which I discussed now. Quickly, it will be patchy calcification. Where do you see? Come on, doctor. Patchy calcification. Am I audible?
Yes, sir.
Patchy calcification between chondrogenic and osteogenic tumors. Patchy calcification. Come on, you have only 2 options. Do wrong, I'll be happy. Chondrogenic or osteogenic? Huh?
Patchy chondrogenic.
Very good. And homogeneous is osteogenic. Where do you see soap bubble?
GCT.
It's also
Adamantinoma.
called osteoclastoma, right? Then where do you see onion peel?
Ewing sarcoma.
And sun ray appearance?
Osteosarcoma.
And what is the system for bone tumors called as?
King's classification.
What is the most radio resistant bone tumor?
Osteosarcoma and all cartilaginous tumors.
Super, super. Now, the next very, very painful point to remember is the bone cysts. There are 2 types of cysts in the bone, doctor. One is called unicameral. Other is called aneurysmal. There are the 2 types of bone cysts. Every examiner will ask, do you know the differences between these 2? We have to be very sure. First, unicameral bone cyst. Uni means 1, no? It comes in first decade. Obviously, aneurysmal bone cyst comes in second decade. Unicameral bone cyst typically in the proximal humerus and in the femur. But aneurysmal bone cysts very often are lower limb. Unicameral bone cysts are central, whereas aneurysmal bone cyst is eccentric. Unicameral are more asymptomatic. You took a radiograph, you discover them. But aneurysmal bone cysts, often patients will develop pain. With pain, he comes in the bone and then you take an X-ray, you discover aneurysmal bone cyst. But the treatment of both unicameral and aneurysmal is curettage. All right. So this is what you need to basically remember. Now, coming to the 4 to 5 points about each of these 4 to 5 points about this bone tumors, each of them you have to be very sure about, which are spotters in the tomorrow's exam. If you look at osteochondroma, doctor, why people develop pain? Most common cause of the pain. It is the bursitis. It is the bursitis, but not. Second is osteochondroma. Then, how do you treat the osteochondroma? We do resection, but the resection is called extra periosteal resection. That is a special way by which osteochondroma is being treated. Then, see, most of the tumors, doctor, arise either in metaphysis or epiphysis. There are only 2 tumors you need to remember that arise from the shaft, that is from the diaphysis. One is osteoid osteoma and the other is Ewing sarcoma. Malignant में होता है Ewing sarcoma, benign में होता है osteoid osteoma that arise from the diaphysis. That's what you need to basically remember. Then how do you, I mean, as I already told you about osteoid osteoma, the commonest benign true bone tumor, if that is asked a question, your answer should be osteoid osteoma. Second thing about osteoid osteoma is the clinical presentation. A lot of times this question is asked. Patient is presenting with pain, which is worse in the night, relieved by aspirin or NSAIDs. Always pain worsening in night, relieved by giving salicylates. You should remember osteoid osteoma. Osteoid osteoma can also occur in vertebra. That is the reason scoliosis can occur because of osteoid osteoma. And what is a classical finding of osteoid osteoma? After this class is over, you should quickly go to the Google images and look for the osteoid osteoma CT scan appearance. There is a nidus, that is one small bony nidus. The presence of this bony nidus is the feature of radiological hallmark of osteoid osteoma is what you need to remember. So how do you treat osteoid osteoma? Surgically, you will remove the entire nidus, and that's called burn down technique. And also you use radio frequency ablation to treat the osteoid osteoma is what you need to remember. Now, the question hour. Are you ready? I'm going to ask you 5 questions, how much you understood, right? Tell me, between unicameral and aneurysmal, which is painful?
Aneurysmal.
Aneurysm.
Very good. Any bone cyst, what is the treatment?
Curettage.
Curettage.
Very good. And what is the age of unicameral and aneurysmal?
Unicameral first decade.
Very good.
Aneurysmal second decade.
Okay. Good. And which is eccentric?
Aneurysmal.
Aneurysmal is eccentric. Very good. Now, extra periosteal resection is the treatment of which bone tumor?
Osteochondroma.
Yeah, you can easily remember. Osteo means bone, chondroma means cartilage. So a bony growth with a cartilaginous cap, that is osteochondroma. Now, what is the location of osteoid osteoma? Epiphysis, metaphysis, or diaphysis?
Diaphysis.
What are the only 2 tumors that you know which are diaphysial?
Osteogenicsarcoma and osteotomy.
Very good. What do you see on CT scan in osteoarthritis?
Nidus.
A bony nidus. Very good. And what is the typical presentation of osteoarthritis?
Worst in night and by size.
Relieved by NSA.
Very good. There is a pain, worse in the night, relieved by giving aspirin. All right. Then what else is the treatment of osteoarthritis?
Radio frequency ablation.
Very good, very good. Is used for osteoarthritis. Good. So what you need to do is, you can go back after this class is over to look for the Google images on how an osteoarthritis looks like, and osteoarthritis on the diaphysis. What is the gross pathological appearance? Those things you can look on the Google. In fact, now also you can look on the Google, no problem. See, the beauty part of a audio only class is your auditory cortex is most receptive part of the brain, more than the visual cortex. We see a lot of visual things, but what you listen, actually, you require attention to receive the listening thing. So that is the reason purposefully we made these sessions every day evening 6 o'clock. Listening sessions, audio sessions, spaced repetition, understanding the concepts, and then at least end of this 1 hour, you should have 40-50 points in your pocket, doctor. After this is over, you need to go back to the reading room and then once more blast these points on your friends.
यार बंद क्या कर रहा है भाई, गर्मी हो रहा है.
Yes, yeah. Now, let's talk about enchondroma. Suppose if I ask you a question, most common tumor of the bone of the hand, your answer should be enchondroma. Typically, there is a syndrome, 2 syndromes you need to remember. Olier's disease is multiple enchondromatosis, multiple enchondromas will be there. Then Maffucci syndrome. What is Maffucci syndrome? Enchondroma plus subcutaneous hemangiomas. Subcutaneous hemangiomas constitutes Maffucci. Once more, you can go to the Google and then check what is Maffucci. And you will have a lot of pictures where a patient with a subcutaneous hemangioma, with an enchondroma, and you will have Maffucci's case reports, which will be available. That is how you need to build that enthusiasm, doctor. Like, otherwise, nobody teaches in medical college. We can't teach. You're all adults to be taught. But you are always wonderful brains, minds who can learn. So, more than teaching, our job as teachers is to inspire you to learn. That's what we do every day religiously. Now, doctor, how do you treat enchondroma? Enchondroma, we do extended curettage just like we do on the bone cysts. Then another important thing you need to know is, typically, there is a risk in all the enchondromas to transform into malignant chondrosarcoma. Enchondroma benign, chondrosarcoma malignant. But generally, a enchondroma, if you come across in the bone of the hand of any person, only 2% chance is there for it to become a chondrosarcoma. But if this enchondroma is a part of Maffucci, 100% chance is there. If this enchondroma is the part of Olier's, 30% chance is there. That is what you need to remember. Then another important point you need to know is chondroblastoma. Chondroblastoma is also called Codman's tumor, another name. Then in the chondroblastoma, there is a special type of calcification that is frequently asked as an MCQ in the exam. It's called chicken wire calcification. Chicken wire. First of all, you should know what is a chicken wire, and then you need to look a radiograph and then compare that with this and then understand. Dr. Google will be waiting for you to show you a chicken wire calcification in chondroblastoma. So don't, all these things, you know, doctor, once upon a time, they are very boring to prepare for entrance. But in the modern time, it is very interesting because everything is available in the YouTube, everything is available in the Google. You don't need any coaching program, any bleaching program. What you need is Spardhaya Vardhate Vidya. Chai pe charcha with Dr. Murali Bharadwaz. Every day we sit together. We all study for about 1 hour, pick up 50, 60 points. Whether it is a good day, great day, bad day, tough day in the hospital, in the college. But 1 hour we all sit together, we get inspired. And this is all what entrance requires, right? Entrance preparation requires. But tomorrow when you become a cardiologist, this chicken wire calcification of chondroblastoma is of no use for you. But to become cardiologist, you have to be a topper in entrance. For that, you need to read all this stupid stuff. All right? So quickly, the question answer time has come. Tell me, doctor, what is the most common tumor of the bone of the hand?
Achondro.
Okay. What is multiple enchondromatosis called?
Ollius
syndrome.
disease.
Very good. And what is the combination of things you see in Makuki?
Enchondroma
Plus subcutaneous hemangioma.
Very good. And where do you see chicken wire calcification?
Chondroblastoma.
Super. Kushwa Gamble. Now comes the next favorite question topic, giant cell tumor. Now, 10 points I will tell about it, and after that, I will ask you a few questions. Giant cell tumor, osteosarcoma, Ewing sarcoma, I will tell you around 15 points. Attentively listen, remember, and reproduce. All right? Yesterday we discussed some points. Day before yesterday we discussed. I think you still remember the Fanconi syndrome, Gitelman syndrome, Liddell syndrome, all those things which we discussed few days ago, right? So before I go to the giant cell tumor, let me check. I don't know who among you are there in that class. Which syndrome is like taking loop diuretics between Liddell, Gitelman, and Barter and Fanconi? Anybody?
Barter's syndrome is loop diuretics.
Very good. And which is like thiazide diuretics?
Gitelman syndrome.
Gitelman syndrome. Very good. And in which, how is calcium in urine in Barter versus Gitelman?
Hypocalcemia.
Barter's hypercalciuria.
Very good.
Gitelman hypocalciuria.
Super. So the point is, at the end of this session, you heard once, without any revision, you should be able to remember it very, very strongly. That is all possible if you're a part of this audio only session, right? Now, giant cell tumor. Tell me what are the 10 points you want to tell. Most common site, giant cell tumor, distal femur. Giant cell tumor by name is benign. Though it is benign, still lung metastasis occur with giant cell tumor. That is one sad part. Then, malignant giant cell tumors, do they occur? Yes. But 95% of giant cell tumors are all benign, but only 5% become malignant. Now, how do you treat giant cell tumor? One of the favorite questions of the examiner. It all depends upon where is the location. Where is the location? If it is the lower end of the femur, you do excision and turnoplasty. Upper part of the tibia, you do excision and turn-oplasty. Lower end of the radius, you do excision with fibular grafting. So this turn-oplasty, if it is lower end of the femur or upper end of the tibia, that is at the level of your knee joint. Whereas in the radius, excision with fibular grafting. This is one special thing you need to know about. Giant cell tumor is what you need to remember. Now, if I ask you a question, most common long bone which is affected by adamantinoma. Generally, adamantinoma is a tumor known for the dentist, jaw bones and all that. But adamantinoma in the orthopedics, it affects the tibia. That's the point you need to basically remember. Now, Osteogenicsarcoma. There are 5 to 6 favorite questions you should remember. You all know retinoblastoma. You all read in ophthalmology, right? So retinoblastoma people not only will have retinoblastoma, they will in additionally have osteogenicsarcoma as the most common extraocular tumor associated with retinoblastoma. So retinoblastoma people will have osteogenicsarcoma. Then another important thing is certain bone tumors are highly vascular. That's the reason they are called as pulsatile bone tumors. Osteogenicsarcoma is very vascular. So osteogenicsarcoma, more than aneurysmal bone cyst, more than giant cell tumor. So these three are pulsatile, but very pulsatile means osteogenic sarcoma. Then another favorite question. Whenever metastasis occurs, even they will also be highly vascular and pulsatile. Vascular and pulsatile. Which metastasis? Renal cell carcinoma and thyroid. These two metastases are called pulsatile metastasis, whereas osteogenic sarcoma, giant cell tumor are called pulsatile bone tumors. That's what you need to remember. So how do you treat osteogenic sarcoma? A very common bone tumor. Chemotherapy. Then we do limb salvage surgery. And in the chemotherapy, we use methotrexate, which is most important component of the chemotherapy of osteogenic sarcoma. And osteogenic sarcoma, just before we discussed, is radio resistant, is what you need to basically remember. All right. Now, few points about Ewing's. Doctor, in the Ewing's, you need to know that if at all a tumor that presents like osteomyelitis, that is, there is a lot of fever, warmth on the overlying skin, pain, all these features of osteomyelitis, it is an Ewing sarcoma which presents like osteomyelitis. Then Ewing sarcoma, typically it involves the shaft. So it leads to a destructive lesion of the diaphysis of the femur. And there is an onion skin periosteal reaction, already you know that fact. Then on biopsy, there is one dirty thing to remember about Ewing sarcoma. What is that? Glycogen positive cells and CD99 positive cells. CD99 positive cells and glycogen positive cells. These are the things that you see in the biopsy in Ewing sarcoma. Once more, it is very interesting. What we do now, Ewing sarcoma, glycogen positive cells. Google image search karo. Beautiful glycogen positive cells, histological picture will be shown by Google. So it's very easy to remember sometimes, but most importantly, these are all frequently asked points in AIMS, PGI, All India. Of course, nowadays it's all INICET, next and NEET PG. If you're going for entrance exam, if you don't know glycogen positive cells are there in Ewing sarcoma, you are far behind the competition. Unfortunately, is there anything related to our intelligence to remember these things? This is all bullshit. But still we need to remember all this bullshit because that is how the entrance exams are being created. Right, doctor? So whether you go for USMLE or whether you go for next or NEET PG or any exam, there is some bullshit part which is inevitable for us to mug, right? But there is a way by which we can remember easily. When we are together like a group, like now we have about 12 of our classmates. So when we have lent our auditory cortex to Dr. Murali Bharadwaz, and he's rapidly doing a gunfire, and after that he's asking them as questions. We are all attentive, and that's how we can easily remember. All right. Now, what is the most common translocation in Ewing sarcoma? T1122. T1122 in more than 90% of people. Then, what is the poor prognostic factor of Ewing sarcoma? A male, age more than 12, and if osteomyelitis features like fever, anemia, increased total leukocyte count, platelets increased, and LDH increased, they're all poor prognostic features. Similarly, any chemoresistance, any lesion which is in the proximal part of the shaft, proximal diaphyseal lesions, chemoresistance, any METs, they all carry very bad prognosis, is what you need to remember about Ewing's. Then one of the favorite question of the examiner is, what is A, B, C, D regime associated with Ewing sarcoma chemotherapy? A for actinomycin D, B for bleomycin, C for cyclophosphamide, D for doxorubicin. A, B, C, D regime is the one which you need to basically remember in relation to the Ewing sarcoma is what you need to understand. I think we did a bit of stuffing into our brain. Let us check how much of that stuff is still there in our brain, right? So the time for asking questions. Are you ready? What's the most common site of giant cell tumor, doctor?
Epiphysis, lower end of femur.
Very good. Lower end of femur. Then, if it is around knee joint, giant cell tumor, what is the treatment?
Excision turnoplasty.
Excision
Beautiful.
turnoplasty.
What is the most common long bone affected with adamantinoma?
Tibia.
Very good. Then,
Tibia.
very good, very good. And in retinoblastoma, what is the most common extraocular tumor?
Osteogenicsarcoma.
Very good. What are the two tumors which are called pulsatile bone tumors?
Aneurysmal bone cyst.
Giant cell tumor.
Yes.
And this giant cell tumor osteocyte.
Very good. Osteogenicsarcoma and giant cell tumor. What are the metastases which are highly vascular and they are called pulsatile metastases?
Renal cell carcinoma.
Thyroid
metastasis.
Very good. Renal cell carcinoma and thyroid. Excellent. What is the most important chemotherapeutic regime in osteogenic sarcoma? Which chemotherapeutic agent is used in osteogenic sarcoma?
Methotrexate.
Beautiful. Methotrexate. How is the radiosensitivity of osteogenic sarcoma?
Radio resistant.
Beautiful. Now, where do you see glycogen positive cells in biopsy?
Ewing sarcoma.
Ewing sarcoma.
Very good. What is the CD marker in Ewing sarcoma?
CD99.
What is the chromosomal translocation of Ewing's?
T11, 20.
T11, 22.
20.
22. Okay. Now, which is the bone tumor that presents like osteomyelitis?
Ewing sarcoma.
Very good. And what is the A, B, C, D, the gene of Ewing sarcoma?
Actinomycin,
Yes.
bleomycin,
Phenomycin, cyclophosphamide, doxorubicin.
Beautiful, beautiful. So that is what you need to remember. Now, continuing our journey of the so-called boring topic called bone tumors, but it is becoming interesting, very spicy. Now we have a lot of points that our classmates are not sure about. Tomorrow we'll go to the reading room and fire the bullets so that all the guys will lose their confidence, right? That job we used to do a lot in the medical college days, right? So, all right. Typically, chondrosarcoma, it is the most common tumor associated with hyperglycemia. Hyperglycemia, that's what you need to remember. Now, doctor, there are three important lesions which are a close differential diagnosis. Osteofibrous dysplasia, fibrous dysplasias. Then adamantinomas. At least these two are considered to be the very important differential diagnosis between the two. Why? Because adamantinomas lead to soap bubble appearance and fibrous dysplasias lead to ground glass appearance. Adamantinomas present with swelling, but fibrous dysplasias lead to deformity. Adamantinomas, tibia is most common long bone. Fibrous dysplasias typically occur in female. Adamantinoma occur in male, but fibrous dysplasia occur in female. And what is the deformity in fibrous dysplasia called as? Typically, when fibrous dysplasia means deranged cells. Metaplasia is one adult cell type converted into another cell type, adult mature cell type. So dysplasia is precursor of malignancy, not metaplasia. So fibrous dysplasia, whenever it affects the proximal part of the femur develops a deformity which is called Shepard-Crook deformity. So once more, in the Google, you need to quickly punch and look for how a Shepard-Crook deformity of fibrous dysplasia looks like. Similarly, look at the radiograph, adamantinoma, how that swelling like appearance of adamantinoma looks like on radiograph on Dr. Google. All right. So will you do it for me? Because in this heat of discussion, if you quickly run into the Google and then do a little bit of Googling and then identify, then you will never forget throughout your life. All right. Now, adamantinoma is more common in male or female? Male. Adamantinoma is male. F is female, F is fibrous dysplasia. Where do you find Shepard-Crook deformity?
osteofibrous dysplasia.
Very good. And ground glass appearance where? Soap bubble appearance where?
Ground glass in fibrous dysplasia, soap bubble and adamantinoma.
Super. So now, doctor, let us quickly go to some more points on metastatic bone disease. Now, what is the tumor that comes to the bone? From which primary does it come? So what is the most common primary that goes to the metastasis to the bone? Breast, more than prostate. But breast and prostate, both of them, but breast, more than prostate metastasis to the bone. Now, if you look at the most common site of primary for bone metastasis in the males, if the examiner asks you that question, what is your answer? Prostate, most common, more than lung. In female, most common primary going to the bone means breast, more than the lung. In children, neuroblastoma is the most common primary that goes to the bone. metastasis to the bone is what you need to remember. All right. Which part of the bone is the most frequently involved thing in the metastatic bone disease? It is the spine, lumbar spine, most common side. Now, which primaries go to the bone and lead to lytic expansile metastasis? It is expansile, it is also lytic. Lytic expansile metastasis. Renal cell carcinoma and thyroid carcinoma. They go to the bone and lead to lytic expansile metastasis. Then, which primary go to the bone and lead to osteoblastic secondary instead of osteolytic? Prostate carcinoma, carcinoid, medulloblastoma. These three lead to purely osteoblastic secondaries. Once more along with me. Which are three tumors that go to the bone and lead to purely osteoblastic secondaries?
Carcinoid,
Good.
medulloblastoma,
Good. What is the most common?
Prostate carcinoma.
Prostate carcinoma. Prostate carcinoid medullary. Prostate carcinoid medullary. Purely osteoblastic. And metastasis, generally, whenever any metastatic bone disease is there, generally, it is very rare. Distal to the knee, distal to the elbow. Suppose if somebody had a tumor in the tibia, it is unlikely to be distal to the knee, and distal to the elbow is very rare. But there are three tumors which can metastasize even distal to the elbow, distal to the knee. What are they? Remember BBC. B for bronchus, B for bladder, C for colon. Bronchus, bladder, colon. Bronchus, bladder, colon. These three can even go anywhere, even distal to the elbow and knee also. BBC can go anywhere. That's what you can remember. B for bronchus, B for bladder, C for colon. All right? Then, a bone tumor, metastasis from bone to bone. Where do you see? Bone to bone metastasis. Osteogenicsarcoma arise in the bone and goes to the bone. Neuroblastoma arise in the bone and go to the bone. Ewing sarcoma arise in the bone and go to the bone. So what is the spelling of bone? B-O-N-E, no? O-N-E. O for osteogenicsarcoma, N for neuroblastoma, E for Ewing sarcoma. Bone to bone metastasis typically are seen in osteogenicsarcoma, neuroblastoma, and Ewing sarcoma is what you need to remember. Then, from the soft tissue, some sarcomas, they can metastasize to the bone. From the soft tissue sarcoma, it arises in the soft tissue as a sarcoma and that goes to the bone. What are they? You can remember Sarla. S for synovial cell sarcoma, A angiosarcoma, R rhabdomyosarcoma, L for liposarcoma, A for angiosarcoma. Synovial sarcoma, angiosarcoma, rhabdomyosarcoma, liposarcoma, angiosarcoma are the soft tissue sarcomas that arise in the soft tissues and then go to the bones. That is what you need to remember. So BBC, bone, Sarla, all the three, now you know very well. Now, suppose if I ask you a question, what is the most common soft tissue tumor in a child? Rhabdomyosarcoma. But if I ask you a question, most common soft tissue tumor in adult is malignant fibrous histiocytoma. Is the most common soft tissue tumor in the adult. So generally, all these things, doctor, first time is a wonder. Second time, you feel, I heard it somewhere. Third time, it is already inside your blood. Fourth time, in the exam hall, you will be anticipating it and attacking the examiner. Oh my God, I was expecting this examiner fellow is asking which tumor will go beyond elbow, beyond the knee. I'm waiting for this, and you will attack. You should reach that stage, right? You should reach that stage before exam. There are totally 1,000 topics, at most 20-30 top points in each topic, not more than 30,000 points, doctor. That's all that you need to master. Every day I will do a revision for you, at least 80 to 100 points in this 1 hour session. And you once more go back and regurgitate all this on your classmates. That is how you will remember. And try to apply all these things whenever you have opportunity in the clinical rounds in the hospital. Automatically, you be with me for about 1 year. Every day, 1 hour, even Sunday, I have no other work. I am completely unemployed MD General Medicine. I love to spend with all you guys. You become masters, that's all. No pen, no paper, no underlining, no writing. Only like Ekalavya, listen with your ears, store in your auditory cortex, repeat it on your friends, and that's how you become a great topper. Right, doctor? Now, with that story in the background, we read most of the things. Quickly, I will ask 4 or 5 points. How much was your attention? Once more, tell me A, B, C, D regime. Where do we use?
Ewing sarcoma,
And what is A, B, C, D is all about?
actinomycin, bleomycin, cyclophosphamide, doxorubicin.
Beautiful. And for which tumor? Paraneoplastic syndrome is hyperglycemia. Did we discuss this?
Chondrogenicsarcoma.
Beautiful. Chondrosarcoma. Chondrosarcoma. Now, overall, most common primary going to the bone. Overall, which is the primary that goes to bone? Come on, doctor.
Breast.
Yeah?
Prostate, breast,
Is it prostate or breast?
and lung.
Breast.
Prostate or breast?
Breast.
Breast,
Now, in children, what is the most common primary that goes to bone?
neuroblastoma,
And what is the most common site of the skeleton to get metastatic bone disease?
Lumbar spine.
Very good. And tell me, what are the lytic expansile metastasis?
Renal cell carcinoma.
thyroid
and
carcinoma, renal cell carcinoma.
Very good. Purely osteoblastic secondaries.
Carcinoid, prostate, medulloblastoma.
Beautiful. And what are the 3 tumors that can go beyond the knee, beyond elbow?
Bladder, bronchus, colon.
Bronchus, bladder, colon.
Very good. Bronchus, bladder, and colon. Bone to bone metastasis?
Ewing sarcoma, osteosarcoma, neuroblastoma.
Very good. And what are the subtler tumors, soft tissue to bone?
Rhabdomyosarcoma.
Very good.
Synovial
Synovial sarcoma,
angiosarcoma,
angiosarcoma, liposarcoma.
Very good. And what are the most common soft tissue tumor in a child?
rhabdomyosarcoma,
And in the adult?
malignant fibrous
malignant
Fibrous
histiocytoma.
Very good. Very good. Very nice. Very nice. So that is all the short story. Now, let us quickly go and discuss about, yes, you still have energy? You still have energy? We have another 7 more minutes for us to discuss. because you cramped a lot of things into brain, no? You will feel a bit exhausted. Where do you find chicken wire calcification?
Chondroblast.
Giving sarcoma.
Yeah?
Chondroblastoma.
Chondroblastoma. All right. So let me quickly take you to a bit about the trauma, right? Now, there are 4 rotator cuff muscles. Can anybody tell me what are the rotator cuff muscles?
Supraspinatus.
Very good.
Infraspinatus.
Good.
Teres.
Teres minor.
Teres minor.
Minor, not major. Okay.
Subscapularis.
Subscapularis. Now, if you look at the shoulder and we talk shoulder dislocation, which part of the shoulder is weakest? Medial, lateral, inferior, superior? Which is weakest? Which is weakest?
Medial.
Any other guess? Any other guess? Come on, there are only 3 other aspects. No, medial is wrong. Then what else? See, medial to the shoulder, you are having all the bony part of our thorax, no? So it's very difficult to dislocate there. Where else?
Inferiorly.
Inferior dislocation is what you need to basically remember. Now, whenever there's any dislocation of shoulder, there is a Hill-Sachs lesion. Have you heard of Hill-Sachs lesion? If so, then which aspect of the humeral head you find a defect, which is called Hill-Sachs lesion? Anybody? Is it anteromedial, posterolateral, anterolateral, posterolateral? Yes. Hill-Sachs lesion is a defect that you see in the bone, in the humeral head, whenever there is an anterior dislocation of the shoulder, and it is typically seen in the posterolateral aspect of humeral head. Once more, what you need to do? This session is only to stimulate you. You need to go back and then check, wow, what is this Hill-Sachs? Let us check, right? Then, if there is a, instead of anterior, if there is a posterior dislocation, then where will be a bony defect in humeral head? It will be anteromedial humeral head. You find a bony defect. And that is called reverse Hill-Sachs lesion. So you can remember R-A-M-P. R means reverse, right? A-M means anteromedial. And where do you find? P means posterior dislocation. So ramp, you can remember. So anterior dislocation, posterolateral defect is called Hill-Sachs. Posterior dislocation of the shoulder, anteromedial humeral head means it is called reverse Hill-Sachs, is what you need to remember. Now, among all our body joints, recurrent dislocation, most common only in one joint, that is shoulder joint. And there are various ways by which the dislocation of the shoulder can occur. I mean, after the dislocation, the humeral head should come and stay somewhere, no? So, subcoracoid type of dislocation is the most common type of the shoulder joint dislocation, and that leads to recurrent dislocation, is what you need to remember. After the shoulder, which else joint most commonly undergoes recurrent dislocation? Patella. Patellar dislocation is second most common recurrent dislocation. And there is one joint which is strongly protected by the ligament. So it's very rare to have recurrent dislocation. Ankle joint is what you need to remember. Now, what is the type of the force that lead to a recurrent anterior dislocation. What type of? Suppose somebody has got a recurrent anterior dislocation. You can in fact reproduce that recurrence of the anterior dislocation. How? You do abduction of the shoulder. You know what is abduction, adduction, right? You can do it on your own joint while I'm telling you. Abduct and externally rotate. Abduct and externally rotate. If you do that, a guy who has anterior dislocation will cry, oh my God, once more this got dislocated. So abduction and external rotation force is the one that reproduces the recurrent anterior dislocation. That is what you need to remember. Now, what are the tests for the shoulder dislocation? Unfortunately, these British fellows, they created a lot of English medicine textbooks, and they created on their own name, right? And the entrance examiner will kill us by asking that names and say, do you know what is this test? So you have to remember. So for the test for shoulder dislocation, Bryant's test, B-R-Y-A-N-T-S, Bryant's test, Dugas test, Callaway's test, Hamilton's ruler's test. These are all bullshit tests, but we need to remember for entrance exam. Bryant, Dugas, Callaway, Hamilton. Very simple actually. Whenever there is any shoulder dislocation, now you put one scale on your shoulder, then there is a straightening which is called Hamilton ruler. So Callaway, you try to look for the circumference of the shoulder. The change in the circumference whenever there is a dislocation is Callaway. So it's very easy. Actually, to understand those tests is easy, but to remember those names in the tomorrow's entrance exam is the most cruel experience. So anyway, these experiences are part of the game. Bryant's, Dugas, Callaway, Hamilton ruler. You promised me that after this session is over, just go to the YouTube, Bryant test. Some guy will be displaying you how to do that. Dugas test. In the YouTube, somebody will be displaying you how to do the Dugas. Learning don't need a teacher nowadays. Learning only require a bit of inspiration. What to learn, somebody should tell you every day. All right. But anyway, quickly tell me what are the 4 named tests to test the shoulder dislocation, doctor, quickly. 4 tests for dislocation. Bryant,
Callaway's, Dugas test, Hamilton ruler test.
Bryant, Dugas, Callaway, Hamilton ruler. After this session is over, please go back to Google, YouTube, and check how these tests are done. All right, that's a bit of homework. Then there are 3 maneuvers. 3 maneuvers. So abduction, external rotation predisposed to anterior dislocation. Opposite to that should lead to the recovery from anterior dislocation, right? So that is what we do to reduce the anterior dislocation. So Cochet's method, Stimson's gravity method, Hippocratic method, they are the 3 methods. Once more, I'm not going to tell you what are these methods. You have to go back to the YouTube and ask Dr. YouTube, can you please show me what is Cochet, what is Stimson, what is Hippocratic? Now tell me what are the 3 methods? Once more. For the reduction of anterior dislocation. Yes, doctor.
Cocker's method, Hippocrates,
Yes.
Simpson's gravity.
Stimson's gravity. What is that oath you take as medical student? Hippocratic oath, right? So Hippocratic method. All right, doctor. So that is the story of 3 maneuvers which you need to remember. So doctor, with this we will call it a day. 1 hour of studying together. My promise to you, every day I'll become your classmate. And thank you very much. I hope you all enjoyed learning today. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, everybody. We'll all meet tomorrow evening once more at 6 o'clock.
Thank you so much, sir.